Okay, let me bring this up here. So thanks for having me. I'm Kristan Alfonso. I'm one of the pediatric otolaryngologists at Children's of Atlanta and part of the Department of Emory Otolaryngology. And I was a former resident at UK, so shout out to UK. Today, I'm going to talk about the approach to pediatric, really infant sensorineural congenital hearing loss. And I don't have any disclosures. Here's kind of an outline of the talk. And I do want it to be somewhat interactive. So if I have some questions, you can send in the answers via the chat function. Make sure I have that up over here. Okay, so we'll go through a case, a definition of congenital hearing loss, some epidemiology, etiology, workup, and then the case wrap up. I have some quick fire questions at the end, and then some just random resources that could help during this time. Okay, so as for the case, this patient, LRS, was a 2-month female who presented to our clinic. She had failed her newborn hearing screen, and that was confirmed that she had failed it unilaterally. She underwent an AVR confirming that, and we'll show that in just a moment. In terms of her history, she had no significant medical history. She was born full term, no NICU stay, no risk factors during her during gestation or during the perinatal period. And so at that point, in terms of her physical, it was otherwise normal. So a CMB culture was performed from a urine sample, and that was positive. So her dry blood spot was sent to the CDC, and it confirmed congenital CMB. This was her ABR. So you can see on the right side, she had no responses. So she had profound sensorineural hearing loss on that side. And on the left side, she had normal thresholds. So in terms of congenital hearing loss, just to start off with the definition, it's hearing loss that's present at birth. And in terms of the numbers, it's about 3 to 4 infants per 1,000 who have hearing loss, which is about 12 to 16,000 here in the US. And one of those has severe to profound hearing loss. And of course, this number rises by the time children enter school, where it's about 6 per 1,000 that have hearing loss. And hearing loss is the most common birth defect. So typically in terms of newborn screening, we're looking at things like PKU, sickle cell, other things like that. But if you look in terms of birth defects, the incidence of hearing loss is much more common than all of these other things that are listed here. And it has a huge impact in terms of a patient's development, as well as educational impact. And so we see that from the areas of sound awareness, speech understanding, language development, educational impact. We know even for unilateral hearing loss that kids on average will be 1 grade behind their peers and have difficulty in different realms, especially hearing and background noise and sound localization. In terms of employment opportunities and earning potential, there's an estimate that it's about $1 million per child in lifetime costs when you have untreated hearing loss, whether this is related to 35% direct costs and then 65% indirect, like lost learning potential. And here in the US, only about 1/3 of candidates actually receive cochlear implants for congenital hearing loss. And of course, when you start talking about adult hearing loss, it's even lower, probably about 5% of candidates actually get cochlear implants. So in terms of the etiology of pediatric sensorineural hearing loss, about half is hereditary and half non-hereditary. For those that are not hereditary, we divide it into acquired and idiopathic. For acquired, these could be environmental causes, so like our torch infections, ototoxic medications, other risk factors that come along during gestation or the perinatal period, the most common of which would be CMB. So that accounts for about 25% of infant-related hearing loss. In terms of hereditary, about 1/3 is related to syndromes like Waardenburg, Pendred, things like that. 70% are non-syndromic, which we are thinking about your connexin 26 mutations. And why is it important that we explore the etiology during our workup of hearing loss? And for a lot of patients, they'll say, you know, or families, they'll ask why you need to look into the reason for it. Some are interested, but others just want to know what you're going to do in terms of intervention. But I do think it's important to provide prognostic information for that patient and the family, identifying any comorbidities. So if you were to find that they had a syndrome, say that you identify as Usher's, then you can help in terms of counseling for future things that could happen, like vision loss. Genetic counseling for family. So if you find out it is syndromic, or if it's autosomal recessive mutation, that there's a chance that the next child could also have the mutation. And then also help guide decision-making for treatment. So starting off with the workup, I'll do a brief discussion just of screening. And so in terms of screening, there's two main ways that screening is performed. One using OAEs, so otoacoustic emissions, and the other one being an automatic ABR. And so in general, and actually up until the 2019 infant hearing statement from the Joint Commission, you would screen with one modality and then confirm with that same modality. And actually last year that changed, where you can actually screen with a different modality. So in general, the recommendation for if it's a well child, you can use either, but most people use OAEs. And then you want to confirm with OAEs if they did refer on the first try. After that, then you would refer, and then they would be confirmed outside the hospital. For patients who are in the NICU or have other risk factors, you want to make sure that you're doing an ABR. And the reason for that is that you're checking for auditory neuropathy, especially with a NICU stay of greater than 5 days, if they have been on the ventilator, if they have had jaundice or other risk factors. You want to make sure you're checking for auditory neuropathy, and you would do that with using the ABR method. And again, they used to say that you would check with the same method, but now that you can check with a different one, I still think using the automatic ABR, especially if you're in those circumstances, is important. So first question, what area of the cochlea is tested by your OAEs? And probably the easiest way is if you want to send things in through the chat function. Perfect, the outer hair cells, great. So DPOAEs is looking for your the sound response from the outer hair cell in the cochlea, the microphonic. And then just as an example here for the automatic ABR as well. Okay, so what is the goal deadline for hearing screening? So we kind of have a rule that we follow in terms of what the goal is for screening, then for confirmation for your diagnostic, and then for your intervention. Any thoughts? Okay, so 3 months would be for your hearing evaluation, 1 month for screening. And actually just of this last year, they're trying to change it to 1, 2, 3. So before it was the 1, 3, 6 rule, where you wanted by 1 month have confirmed your screening, 3 months had your hearing evaluation to confirm your diagnostic, and then by 6 months having early intervention. And this really differs by state. And so it doesn't mean that you have to be fit with your hearing aids or have your surgery by 6 months. Honestly, it just means that you're put into some kind of early intervention program, whether that means that you're having services, auditory verbal therapy, something like that, that means that you're completing that thing. But right now they're trying to change to the 1, 2, 3 rule, which will be even more challenging, especially because in certain states, like here in Georgia, we struggle even just trying to get towards the 1, 3, 6. Okay, so now you've confirmed failed hearing screening. What are you going to do next? So overall, everyone agrees that the most important thing to start out with is a directed history and physical. So in terms of looking for risk factors that can contribute to sensorineural hearing loss, asking about the torch infections, especially asking about birth weight, if they had jaundice. And actually, in terms of jaundice, we know that even just having hyperbilirubinemia increases your risk of sensorineural hearing loss, despite requiring any type of phototherapy or exchange transfusion. ototoxic medications that are longer than 5 days. And so the common one would be asking about like gentamicin, if they were on that. That's a commonly used one in the NICU. Other ototoxic medications like furosemide or vancomycin. Bacterial meningitis, if they've been on the ventilator greater than 5 days. Any history of head trauma, neurodegenerative disorders, NICU stay greater than 5 days, and family history of hearing loss. So that would be their main questions. And then of course on exam, looking to see if you see any signs that could contribute to a syndrome, like if you're seeing any pits, cleft lip, cleft palate, things like that. Okay, and then you're going to confirm with your diagnostic ABR. And so typically you can do a sleep-deprived ABR up until about 4 to 6 months of age. And then older than that, probably sedated, just because it'd be hard for them to sleep through it. And so use that for confirming now at this point. So this is the 3-month goal, so that you'd have your diagnostic done by that point. Okay, so you've done your H&P, they've seen audiology, now what? So you can do labs, there's genetic workup, seeing ophthalmology, EKG, and imaging. Then the big question is, which one of these would be good to do next? Is it good to just do shotgun method, order all of it, or try and focus more in a targeted way? So first of all, over the last several decades, a lot of different algorithms have come out, and it's really changed as certain things have optimized from our imaging as well as from genetics, from going from directed genetic testing to now we have comprehensive screens. So this has really changed over time. This is the one that I tend to follow, which emphasizes workup of CMB first. So this comes out of Utah with Dr. Park. He published it in 2014. And it's I like this algorithm because of course it's focusing that you're doing your history and physical audiology first. And then if you're not sure, then the next thing you're gonna do is workup of CMB. And really workup of CMB is going to be the most time sensitive thing that we have. In many states, this is very state dependent in terms of whether CMB workup is required or not. And in certain states, the dry blood spot, which is what you're using to confirm your CMB, we'll talk about that in a moment, is only kept for a very short amount of time. And so this is the one time sensitive thing you really need to try and do. If that's negative, then you can go down the algorithm in terms of your genetic testing, imaging, optho, EKG, and we'll talk about what order of doing those is good, and in terms of what to focus on for each of those things, and then kind of go from there. So talking about labs first, traditionally, probably in the early, or the 1990s, 2000s, a panel of routine tests was ordered, like looking at CBC, BMP, urinalysis, cholesterol, autoimmune panels, thyroid panels, checking for syphilis, urinalysis we talked about up there. And the goal at that time was that you're trying to rule out different things with each of those that you could be screening for. So say if you're doing your CBC, you're looking for ruling out leukemias, platelet studies, BMP and UA, you're looking for ruling out Alports, diabetes, assessing for hyperlipidemia with your cholesterol test, autoimmune, looking for lupus or other autoimmune diseases, thyroid, looking for pendrid, but of course, over half of pendrid patients are euthyroid, so that's not going to help entirely with diagnosis of that. And then, of course, the great confounder being syphilis. There was a good study that was published in 2002 by Mafang et al. Looking at the diagnostic yield of doing these laboratory panels in patients with sensorineural hearing loss. And the diagnostic yield is very low, 0 to 2%. And so I think it's best to use these just for excluding or confirming other testing, and just doing a wide kind of panel is not going to be helpful for you during your workup. The caveat being CMB. So again, CMB is the most time sensitive thing that we have to work up, and it can contribute to 1/4 of all infant hearing loss. It's the most common congenital infection worldwide, the #1 cause of non-hereditary hearing loss. The incidence is greater than combined incidence of all metabolic and endocrine disorders that we currently test for in the dry blood spot screening panels. So 27 different disorders are screened for at birth in the US, and we identify about 6,500 cases a year, but there are 38,000 cases of congenital CMV each year. So I think, especially in the last decade or so, there's a big push in terms of trying to make sure that you identify CMV early, and then looking into different trials of things that we can do to help stabilize and help prevent progression of hearing loss in these patients. 90% of the congenital CMV is asymptomatic, so they're not going to be showing signs of like CMV retinitis, microcephaly, epilepsy, having premature birth, other organ dysfunction. Out of these patients, up to 15% can have sensorineural hearing loss. And it can be unilateral, it can be bilateral, it can be mild, it can be severe, profound. And actually, CMV is the second most common cause of having unilateral deafness. 10% of congenital CMV is symptomatic, showing these other organ system dysfunction, and out of those, half have sensorineural hearing loss. In terms of your diagnosis for congenital CMV, there are several tests that can be done. Generally, urine PCR is the standard. You can do saliva swabbing. It does have a high sensitivity and specificity, but the problem with it is that if the infant was breastfeeding, there is a chance of cross-contamination. And so if you were going to do saliva testing, you would need to confirm that with urine testing. You can do serum testing. Again, you can have maternal antibodies that cross over. And so I do think serum testing helps for ruling out congenital CMV if the patient is if they don't have the dry blood spot anymore. So we'll talk about that in a moment. So the dry blood spot is what's taken at birth, and you can go back and test off of that to do CMV testing. Generally, what you're going to do, if it's less than 3 weeks after birth, you can do urine testing, and that's diagnostic. You don't need to do any further workup. If it's after that, though, you need to confirm with your dry blood spot. The dry blood spot is kept for a different amount of time per state. In Canada, it's kept up until age 18. In the US, it really varies. Here in Georgia, we keep it a grand total of 3 months. And so it's a real big push. Sometimes they lose it and we get to find it around 5 to 6 months of age. But generally, it's a very short amount of time we have to work with. So this is really the most time-sensitive thing that we look for. So back to that case study, that patient had a positive CMV urine culture. Hers was actually done by shell vial assay. This was back when I was a fellow at Texas, but generally most places are using PCR at this point. In terms of congenital CMV, it is important to follow long-term. You can have stable hearing loss. You can have progressive hearing loss. It's very unpredictable. Generally, the recommendations are that you're going to follow at 6-month intervals with hearing testing for the first 3 years, and then annually thereafter. It's also very important that they're going to see ophthalmology to follow for any retinal changes. So Dr. Park from Utah also started the ValEAR Trial, which is currently enrolling patients. We are a site here. And so the goal is looking at, for patients who have isolated hearing loss and congenital CMV, randomizing them to either a placebo versus valganciclovir for 6 months to see if it can help stabilize the hearing loss. And so valganciclovir is the oral form of ganciclovir, which is an IV medication that's generally used in symptomatic congenital CMV. And so this is the trial that's currently going on. Okay, so now you've kind of thought about your labs, your first thing thinking about CMV testing, where to go from here. And so most people would agree that these days genetics should be the next thing that you think about, especially now that we have comprehensive genetic testing with next-gen sequencing, and it's available at such a lower cost than it used to be. So Back in the early, probably 2000s is when directed genetic testing became more widely available. And the first thing that you would really look for would be your GJB2 mutations that could affect connexin 26 within the cochlea. And so this is the most common mutation for hereditary non-syndromic hearing loss. And at that time, it would maybe be, I mean, it could be into thousands of dollars that you're paying for it. Even recently, maybe hundreds of dollars just to test this one. But now that this next gen sequencing has come out, it's made it a lot more affordable where you can widely screen a whole lot of mutations at once. There's a lot of different companies that have it. We use GeneDx, and it's very affordable, even without insurance. I think the most that they would charge a patient is like $600, and then they have all these financial plans. And so it's really remarkable how much that can be done from it. It's a blood test. It comes back in 4 weeks through my email, and they even provide like free genetic testing. I have no financial disclosure for this company, but I do think that having this available really helps, especially when you're considering that in some areas you might not have any geneticists, or it's going to be a very long wait for them to get in to see genetics. And so the fact that you can start this process early can really help make an impact for families and help with your discussion in terms of plans for that patient. There was a study that came out last year out of our institution looking for using these kind of comprehensive screens for patients with non-syndromic hearing loss, and it can help in up to 60% of cases to lead to a diagnosis. All right, so in terms of ophthalmology, this one's a little bit more straightforward. It's really recommended that all children with sensorineural hearing loss undergo an ophthalmological evaluation by a pediatric, or at least an ophthalmologist that is comfortable with pediatric evaluations. This recommendation came out of the American Academy of Pediatrics in 2007. And there's been several studies that confirm that even in patients who have even just mild sensorineural hearing loss, there's not really a big change between mild to severe in terms of the findings you might have on an ophtho exam. Up to 60% can have exam findings, even if it's just refractive error. And then obviously, if the patient has Usher syndrome or that you might be concerned of that, looking for a retinal exam. This might be something that appears more at an older age, like in their teens or 20s. But I think it's important to have them seen by an ophthalmologist at some point. Usher syndrome is the most common cause of autosomal recessive syndromic hearing loss. In terms of doing an EKG, so the thing that we're really assessing for is long QT syndrome, Dravet-Lang-Nielsen. Obviously, this is exceedingly rare. Most people will tell you that they've never diagnosed it in their career. That was something that Dr. Jones used to always tell us. But I think that it's something that's non-invasive, it's fairly inexpensive, and of course, if you catch it, that could be life-saving. The main things that you would be asking for that could be related to this, which is important in your history, is any family history of sudden death. And then generally, patients that have Dravet-Lang-Nielsen are going to be bilateral, more severe to profound hearing loss. So not necessarily going to be that patient that presents with like a unilateral hearing loss. But again, I feel like in terms of the trains of thought, it's something that's easy to do. And so I generally order it for all sensorineural hearing loss patients. Okay, and last but not least, imaging. So this is one that's really changed over the last couple of decades as well, deciding which would be the better imaging in terms of CT or MRI. Obviously, we're talking about this for workup in terms of your imaging for the OR, if you're planning to do surgery. We'll chat about that in a moment as well. With CT, the pro being that if it can help you better in terms of maybe your surgical anatomy, your bony inner ear abnormalities. It's cheaper and faster than doing MRI. The cons being that you're exposing the patient to radiation. You could miss nerve anomalies, possibly need sedation for it depending on age. with MR, the probing, it's going to help you better for your intracranial CNS findings. So sometimes this could actually show you signs of CMV just from the MRI. Anomalies involving the nerves, membranous labyrinth and auditory pathway, no radiation. The con being it's longer, acquisition time, more expensive, generally going to need sedation up until about age like 4 or 5 when patients are better at sitting through it. Really, it started out being more CT, but in the last few years, I think more people agree with doing MR. I really like this study that came out of Toronto Sick Children's with Dr. Cushing et al. Looking at the efficacy of a selective imaging paradigm. So they looked at doing MR for everyone and then selective CT. So that meant in patients who were syndromic, say with charge or something like that, or had a history of maybe labyrinthitis ossificans, they would plan to do an MRI with CT. For patients that on their MRI showed signs of cochlear malformations, not necessarily like Mondini or EVA, but if they had enlarged vestibular aqueduct, but if they did show signs of having like IP1, other cochlear malformations, things like that, then they would do a CT after that. And they showed that they only needed to do it in about 10% of cases. And so that helped in terms of not just expense, but also radiation for patients, exposure, time that they're under sedation, things like that. And in general, the way that I think about it is that CT is going to help you for your surgical planning, but for the most part, when you get in there, it's really when you're going to decide based on your view through the facial recess or so in terms of if you need to do a cochleostomy. And it doesn't really, those are things that you can maybe make decisions in the moment. Where with MRI, if it's going to help you pick up with more malformations or abnormalities, then that's really going to be the goal. And so there was a paper several papers have come out in the last couple of years showing that MRI was able to show more or help more with etiology than CT, up to 10% more of the time. So here's an example of when you're looking through a sagittal view on your T2 MRI through the IAC. And so here's our general reminder of facial nerve being 7 up in the anterior superior quadrant, coke down. And so you can see this would be a normal view. But then in cochlear nerve aplasia, you can see on the left side, that picture, you don't see the cochlear nerve there, at least it's hypoplastic. On the right side, B being normal. And so the most common cause of having unilateral hearing loss is having cochlear nerve deficiency. And so I do think it's valuable to not just say aplasia. You can say aplasia versus hypoplasia, small or absent nerve, or cochlear nerve deficiency, which is really the group term for all of those things. Because if this patient in picture A had responses at some point, obviously there's a nerve there. It just might be like a wisp of a nerve. And so I think that that's an important just consideration for the radiologist to make when they're reading these scans or when you're thinking about it as well. Okay, so in summary, let me bring that back up. Okay, 9:30. Okay, so in summary, I do think a targeted, tiered, systematic approach is best. Even the recommendations that came out from the International Pediatric Otolaryngology Working Group in 2015 kind of agrees with this model where your history and physical is your first thing with your audiological findings, and then you move down the pathway, CMB being the most time-sensitive thing that can help you with your diagnosis of, or the etiology of the hearing loss, and then working through the rest of it. I think that the comprehensive genetic testing is really our next thing that we're looking for, and then going down the route of imaging, and then all patients getting an opto and EKG eval. Okay, and just in conclusion for that, the case presentation, this patient ended up having a normal MRI, and then she underwent a right-sided unilateral cochlear implant. As of last year, FDA approval came out for doing that. She was a little bit off-label since she's under the age of 5, but has been doing well with that implant. I do have some rapid fire questions unless anyone has other questions first. Okay. So say you have a CT, it shows a 1.5 turn cochlea, no interscalar septum, enlarged vestibule, and an enlarged vestibular aqueduct. What would you call this malformation? Perfect, Mondini. Patient presents with congenital hearing loss and euthyroid goiter. Pendred, awesome. Okay, syndromic hearing loss associated with fatal arrhythmias in the family. Look, JLN, Javel Lang Nielsen, great. Long QT. Okay, a patient presents, they have fluctuating hearing loss with rapid decline after a blow to the head. CT criteria to make this diagnosis. Two-stage question. So what do you think? Okay, yep, I agree, EVA. And so it's greater than 1.5 millimeters. So the other thing you can do is you can compare it to your size of the posterior semicircular canal diameter. And if it's larger than that, then that's also another way that you can compare that for the enlarged vestibular aqueduct. One thing about, so in some people call it EVAS, EVA, with that, one of the changes that's been kind of happened over the last few years is that people used to recommend always wearing head protection for these patients if they were going to be doing any kind of risky activity, avoiding contact sports. But studies have shown that it doesn't really make a difference in terms of doing those precautions and the risk of having worsening hearing loss, that it can happen even after very simple I wouldn't even call it head trauma. Sometimes it's even been noted that after like maybe getting out of the car and they bump their head that you could have some hearing loss. And so that generally not recommending them to avoid other activities or wearing head protection. Okay, most common protein mutation of hereditary non-syndromic hearing loss. Connexin 26, perfect. So that's your GJB2 gene. Most common cause of non-hereditary hearing loss, sensorineural hearing loss. Yep, congenital CMV. Most common autosomal recessive syndromic cause of hearing loss. Yep, Usher's. So 4 types of Usher's. Okay. All right. Awesome. And then I just included some random resources, especially being here in Atlanta, lots of driving. So I think I have some podcasts and some things on here that I do recommend, especially as in training, to sign up for. So if you aren't signed up for Dose Daily, you should sign up for it. So this is like a daily question that's sent out through your email, and then they kind of go over maybe recent literature that supports that finding. Also, Academy Q has a lot of like question banks and things like that. These are some websites that I found really helpful, especially csurgeries.com is really great because they have a lot of peer-reviewed videos of surgeries and that you can watch. Sinus videos and the sinus anatomy website is really helpful too. And then as for some podcasts, I really like listening to these ones. Frequency is the official like AAO one, and they've been putting out some really good ones even this past week relating to COVID. ENT Expert Opinion is one where they kind of interview certain otolaryngologists and different subspecialties on different topics is really good. RX Fierce I really like. That one is more looking at women in medicine, but I think overall, like the conversations that they have on there is really awesome. They also just came out with some more recent episodes too. All right. So I think we finished a little bit early, but if you all list of websites again. Yep. But any questions? Yeah, I miss you guys. I hope everyone is staying safe. Interesting times. Okay. All right, we'll finish a little bit early. Thank you guys. Good luck with everything.